My name's Amanda Morgan. I've been part of the lay committee organising committee, and I'm here with Sally Ann Clark, who's a co-committee member, and we're chairing this session, which I think will be really interesting. Particularly, there's been a few sort of messages about the pregnancy rates going up with modulators, and that's fantastic news. So we're here to sort of deep dive into that a little bit more. We've got some great speakers. Our first speaker is actually coming to us via video, so on the screens. So I'd like to introduce CF and fertility in male perspective. Mark Cushway was our presenter for this one. Mark's a successful business leader. Being one of the longest survivors of cystic fibrosis in the world, Mark's a passionate advocate for good mental health, daily exercise, and being a healthcare advocate for yourself. He's helped guide dozens of people with CF through transplant journey, both pre and post-transplant. He's led corporate teams to participate in fundraising activities like the 65Ks for 65 Roses Walkathon and the 21K Walkathon, as well as the annual Push-Up Challenge. Mark's focus on the importance of being your own healthcare advocate, along with a consistent daily healthcare and exercise routine, has helped him constantly defy the odds of living successfully with a life-shortening disease. Please welcome Mark via video. Thank you.
Thank you for this opportunity to speak with you about cystic fibrosis and fertility from a male perspective. I'm honoured to speak to you about my family's journey to today. My name is Mark Cushway, and in the 1960s, when I was born, the life expectancy for a person born with cystic fibrosis was just 15 years of age. Thoughts around life as an adult with CF would have barely been discussed. I've seen my sister pass away from CF at the age of just 13. Many dozens of friends lose their life to this abhorrent disease. Amid all this sadness, hardship, emptiness and isolation that is a life with CF, we see and appreciate the most beautiful aspects of this world, the value of every single breath, and the value of a new life. Fertility issues are an area men and women with cystic fibrosis have a very strong interest in, and yet there is scant information available on cystic fibrosis and fertility. So what do we know about CF and fertility? For men with CF, we know that 98% of us who have cystic fibrosis are infertile. There is a difference between infertility and sterility. Men with CF are infertile, not sterile. For men, this means that the vas deferens is not intact or is missing. But the sperm are not. The sperm are there. 90% of men with CF can have biological children through IVF. CF men go through a sperm harvesting to collect sperm to be used in an IVF procedure. A study from 2005 revealed that only 6.4% of men with CF in Australia have children using assisted reproductive technologies. In the UK, a cohort study from 2013 reported an even lower figure of just 1% of men of a reproductive age receive fertility treatment. The main type of assisted reproductive technology treatments is IVF. The average out-of-pocket per round of IVF is around $10,000 per cycle. For women with CF, what do we know? Most women with cystic fibrosis can become pregnant and achieve normal pregnancy. Based on research provided by the Cystic Fibrosis Foundation in the US, 85% of couples were able to conceive within the first 12 months of stopping contraception. This figure is pre-CFTR modulators. In the UK, pregnancy rates in women with CF were around a third of the national average, with 70% live births. Modulators increase this rate. So here we are today, where the seemingly impossible has become my reality. When I was born in 1962 with cystic fibrosis, the idea that a baby with CF could reach the age of an adult, run a full-time business, get married, and have a family would have seemed impossible. And here I am, a father, a husband, and a business owner. I'm 7 years post-double lung transplant. These are the headlines. They're bold and they're strong. The The story under each of these is far more complex. It is weak and fragile. It is challenging and at times absolutely heartbreaking and soul-destroying. But at the very same time, it is a story of mental toughness, endurance, insane hopefulness, and a life of enormous reward. Having CF and considering a family raised all sorts of questions for my wife and I, around my reduced life expectancy, the daily burden of how I was going to manage a chronic illness, run a business, and not only raise our little girl, but be there for her. These huge questions people with CF deal with, over and above all the massive big questions of life. Today I want to focus on one single point. In fact, even more specifically, I'd like to focus on a single cell, which today is a powerful, wondrous, creative, smart, gifted world changer. I could not have imagined how wide-reaching, how crazy and wild, how hard and full of wonder the journey to today could have been. When our daughter Emmanuel, was born, I didn't ever expect that I'd be alive to celebrate her 18th birthday. I didn't in my wildest dreams expect I would see her off to uni in Sydney, and I certainly didn't expect she'd be a bigger Bowie fan than me. When my wife and I wanted to have a family, we were at a loss as to why we couldn't fall pregnant. At that time, I had no idea about the connection between cystic fibrosis and infertility. It was 20 years ago when my GP suggested that we go see a urologist to search for answers. For my whole life, I was being treated for cystic fibrosis-related chronic lung infections by my GPs and lung specialists. I came across very little information, or was told very little then about cystic fibrosis other than it being a lung disease. I was reactive, always reactive, not proactive about my treatment. After being referred to Dr. Eschman, a urologist in the city, all that changed. He did the necessary tests and told me my vas deferens hadn't developed properly. I didn't really understand how that related to living with cystic fibrosis. He explained that CF was a multifaceted disease that affected multiple organs. He said the vas deferens not developing properly was an aspect of being born with cystic fibrosis, and that 98% of men with CF were in my position. He told me I wouldn't be able to father a child biologically without assistance. From a fertility clinic, because the vas deferens, the tube that carries the sperm, was broken. I really did struggle to get my head around this. I was shocked and overwhelmed. I felt that there was something wrong with me. Deep down, I felt like a failure. After I spoke with CF friends and did more research, I started to come to terms with the fact that the only way we could have a family was through assisted reproductive technology, techniques such as IVF. We were pointed in the direction of the IVF fertility clinic in Maroubra. He also suggested I speak to the CF clinic at RPA. I balked at this for many, many years. I'd spent decades keeping CF in the background and just dealing with it myself. My whole life, in fact. That meeting with my urologist was both life-changing and empowering. The first session with our fertility specialist was, for me, another life-changing moment. At our very first meeting, before he talked to us about the whole IVF process, he looked over at me and he said, "You know, it's not your fault, Mark. It's nothing you have done." "Oh, no, yeah, I know." Then the doctor paused for what seemed like forever, and he repeated himself, "It's not your fault. It's nothing you've done. You were born like this." That really hit me. As part of the process, the fertility doctor sent us off for sperm harvesting at Prince of Wales Day Clinic. Dr. Eschman saw us straight after the procedure and said, "Mark and Lee, we extracted millions of sperm and they look really strong." I was in so much pain, but I cheered. I felt like a hero. For men with cystic fibrosis who go through sperm harvesting, what to me is absolutely extraordinary is that the sperm that is extracted through harvesting is virgin sperm. It is the first time sperm has left our body. That is both profound and incredibly special. Lee started the IVF procedure for sperm growth and harvesting. Only one egg was strong enough to make it through the process. We were shown the cell divided into 4 in a petri dish. The embryo had 4 cells was then implanted into Lee. After 8 weeks in September 2005, Lee was pregnant on her first cycle of IVF. Emmanuel Kate Cushway was born at the Royal Women's Hospital in Randwick on the 24th of April 2006 at 12:05 a.m. in the morning. She literally flew out into the world. Em was born in the cool, a rare event where a baby is born still inside the intact sac. The nurse handed Em to me after she took her out. I held her tight and burst into tears. Em's arrival into the world changed our lives forever. After our little girl was 2 years old, we planned to expand our family with an additional IVF cycle. We thought that the first cycle was so smooth it would be smooth again. But it doesn't work like that. Lee was in her early 30s, and for a woman 30 to 34 years of age, they have a 36.5% chance of a live birth. For women 35 to 39, the opportunity drops to 25.3%. We tried another couple of cycles and weren't successful after implantation. As a result, we decided that the 3 of us were complete as a family. We used to get asked, "Is Em your only child?" What we realised is that having Em is that when it comes to having children, there is no such thing as only one, or just. The 3 of us are a complete family. All up at the time, we would have spent about 25 to 30,000 in our 3 rounds of IVF. The cost, whilst it seems daunting, is very small when you consider the potential outcome. That said, I think that the cost of IVF and the questions around life with cystic fibrosis and our life expectancy are perhaps the main reasons why only 6.4% of men with CF have a family. With only 6.4% of men with CF in Australia and 1% in the UK having a family, there is a very strong argument for men with CF and their partners to receive assistance to go through assisted reproductive technologies. At 18, Emma's now coming into her own. She's a wonderfully intelligent, creative person who I never thought I'd be so privileged to be referred to as her dad. Em has just had her very first paid writing work published. She has an extraordinary future in front of her. I look forward to celebrating her 21st birthday in a few years. Thank you.
Thank you, Mark. I'd like to welcome to the stage for a clinical perspective on fertility, Clinical Professor Siobhan Mulrennan. Siobhan is currently consultant at Sir Charles Gardner Hospital in Perth, Western Australia, and Director of the Adult CF Service. She's currently co-chair of the Thoracic Society of Australia and New Zealand CF Special Interest Group and Centre Director Committee from 2020 to 2023. Currently a member of Australian CF Data Registry Committee and the Australasian CF Standards of Care Committee. Her special research interests include CF clinical research and population-based respiratory health research. Currently principal investigator for CF and bronchiectasis clinical trials at the Institute of Respiratory Health. Welcome.
do you move forward? Green. Okay, I'd like to thank the organisers for inviting me to talk today. It's my great pleasure to discuss fertility and pregnancy in cystic fibrosis. And it's been very topical throughout the whole of the conference that started over the weekend. So these are my conflict of interests. So I think this picture very much encapsulates the current mood with regard to parenthood in cystic fibrosis. There's joy and hope, and a lot of hope for the future. So I think there has been a transformative change in survival outcomes, and along with that, we need to focus on fertility and health in cystic fibrosis, and it should really be part of the comprehensive care that we give. So with this change in life trajectory for a large number of patients with cystic fibrosis, a number are embarking on parenthood. And we've got recent surveys that identify that about 70 to 80% of people with cystic fibrosis are now plan or desire to become parents. And because of this, we need to, there's an importance with regards to education, support and management around family planning and pregnancy. So the objectives of my talk, I'll touch on pregnancy rates, which has been discussed previously in the conference. Also touch on contraception, genetic counselling, fertility. I'll discuss outcomes in pregnancy, and we've got a lot of historic data on this, but not so much in this current era of CFTR modulator. Discuss preparing for pregnancy and what we do with medications during pregnancy, and I'll also give you a sneak preview of the standards of care recommendations with regards to fertility, pregnancy and parenthood. So, I think we've seen this graph before. These are pregnancy rates in America, and we can see from 2000 to 2020, there's been over a threefold increase in the pregnancy rates. And when we look at Australian CF data, registry data, 2019, there were 13 pregnancies that year, increased to 72 in 2022. And I think updated data from Susanna at Ahern this morning showed that there were 88 pregnancies in 2023. So coming on to fertility now, and I think Mark very eloquently described some of the trials and tribulations with regards to fertility in males. So I'm not going to dwell on it too much, but just to reiterate what he has said, 98% of CF males are infertile due to azoospermia, that's absent of the sperm in the semen, and that's related to either partial or complete absence of the vas deferens. Important to note, there's normal sex organs function and normal sex hormones, and as Mark demonstrated, we need to have discussions with regard to this in the adolescent period. So when people are transitioning through adolescence, we want to have those sensitive conversations, because you don't want to actually have a situation, as Mark demonstrated, where people are completely unaware of this fact. Fertility treatment is available. Mark described ICSI, intracytoplasmic sperm injection plus IVF. And I won't go into that in detail, but there's some excellent websites available. IVF Australia have some good videos if required for further education. Now moving on to CF and female fertility. The CF transmembrane conductance regulator is found on the cervix, and in health the water content of the cervical mucus varies, and it's a peak hydration at ovulation. But certainly in the past it was felt that cervical mucus in CF was not as hydrated and more tenacious, and potentially that led to subfertility. Another reason that there might have been reduced fertility in the past is if people were unwell, had low lung function and malnutrition, and that led to secondary amenorrhea. But as the graphs show, that big improvement and increase in pregnancy rates, and certainly I've noticed in the clinic, even prior to the CFTR modulator era, that more females were able to conceive naturally without any assisted reproductive techniques. And so I think another thing that we need to recognise is the importance of counselling with regards to contraception. People that were previously subfertile and they weren't becoming pregnant are suddenly becoming pregnant far more easily. So if you don't want that to happen, we need to highlight the importance of contraception. Now, with regards to pregnancy, ideally it should be discussed prior to with your CF team. It doesn't always happen, and we manage that anyway, but it should be discussed so that we can optimise physical health and ensure the best outcomes for mums and babies. So we deal with pregnancies and parenthood within the CF team in a multidisciplinary approach. And these are some of the questions that I get asked when people come to clinic. From the point of view of males and females, what do I need to do to prepare for pregnancy? Will pregnancy affect my cystic fibrosis? What do I do about my medications? Can I take them? What happens if I get sick during pregnancy? And who will look after my obstetric care? So, important part of the preparation is that the person with CF should come with their partner, and that's so that we can do genetic genotype testing of the partner. So that's a blood test, and we then determine whether or not the partner is a carrier of the CF gene. If they're not a carrier, that's more straightforward. The child will not be born with cystic fibrosis, but will be a carrier, but unaffected. But if they are a carrier, if the partner is a carrier of the CF gene, then there's a 50% chance that the child will have CF. And in those circumstances, important to refer to genetic counselling. We can then at that time discuss pregnancy and fertility treatment if that's appropriate. So preconception counselling, I've mentioned genetic counselling, important. We also counsel with regards to the severity of disease and life expectancy. But in the area of CFTR modulator treatment, that's really been turned on its head given the survival rates. In the past, counselling might have focused on potentially life expectancy and not being able to see your child grow up, but that landscape is very much changing at the moment. We also would then instigate folic acid at that time. So if we turn back the clock and look at outcomes in pregnancies prior to the CFTR modulator treatment, there was actually already a lot of very positive data with regards to pregnancy and cystic fibrosis. So there's two excellent studies in the 2000s which really showed that the pregnant group didn't have any worse outcomes and actually were healthier and didn't have a shortened survival, and that women with CF could actually experience pregnancy with an impact on respiratory and nutritional health similar to a non-pregnant female. So prior to the CFTR modulator treatment, there were still positive outcomes. There were, however, increased risk of diabetes and also increased healthcare use. And just a summary of that data in the pre-modulator era, so maternal outcomes, the risk of diabetes, risk of respiratory infections and increased healthcare use, preterm labour, and also gestational hypertension and preeclampsia. Infant complications that were noted would be increased rate of congenital abnormalities, but that seemed to be linked into diabetes, jaundice, the need for C-section, and premature delivery. If infants were born early, then they did have an issue with reduced lung function and lower gestational weight. And I think important to highlight that need for diabetes screening. So during pregnancy, we would do 2 sets of oral glucose tolerance tests because important for the maternal health and also for the fetal health. So when is pregnancy not advised? And I don't seem to be having these conversations at all, really, in the current era. But in the past, when there was severe lung function impairment or extreme malnutrition or psychosocial instability. And as I've said previously, the CFTR modulator era has changed outcomes and continues to change outcomes in pregnancy. There is a prospective study ongoing at the moment, so that's been led by Jennifer Taylor-Koza in America, and they are looking at maternal and fetal health outcomes. So it's a prospective study, international study, and that data in the next few years is really going to be helpful in advising and counselling pregnant females with cystic fibrosis. So this is quite a busy slide, and I'm not going to go through it in detail, but it's an excellent checklist which shows the things that we usually try to do in clinic: pre-pregnancy, during pregnancy, and after delivery. Pre-pregnancy, we want to optimise health, make sure that vitamin levels are normalised. We look at mental health screening and diabetic screening. During pregnancy, we assess every month to make sure that there's no clinical deterioration, and that's very much with collaboration and good communication with the obstetric teams. So in Perth, we have links with King Eddie's Hospital, which is a tertiary centre. And then after the delivery, it just doesn't stop there. We've got to keep a close eye on physical health and mental health post-delivery. So, looking at CFTR modulators in pregnancy, this is often a question that we get in this current era. We need to assess the impact of maternal risk of continuing therapies versus no therapy at all. If they stop them and they get clinical deterioration, this is not a good thing. And then we need to look at the fetal risk of uncontrolled maternal disease, and then focus on the known and unknown risks of therapy on the neonate. And at present, there's a paucity of data, but the Mayflowers study will help with that. If there's maternal pulmonary decline, weight loss, or inability to gain adequate weight, then we would advise continuation of CFTR modulator therapy. And just a shout out to the team at Charlie's with regard to this letter to the editor in 2020, which really highlights all of those issues and that decision making. And it's a very personalised decision making between the CF care team and the female with cystic fibrosis at the time as to whether they continue, do they come off it for some of the pregnancy, and the safety surrounding that. So surveys on the impact of CFTR modulators in pregnancy. This is combined data from 2 different centres. So they surveyed the modulator use and what people were doing. And they looked at people that were having it either part or all of the way through their pregnancy. The miscarriage rate on modulator treatment is less than 10%. And interestingly, or importantly, cessation of modulator treatment resulted in health decline in 36%, necessitating CFTR modulator treatment. So this is good data when we are counselling females with CF as to whether they should continue with treatment. There were no modulator-related complications reported in infants exposed in utero. So again, reassuring when you're making those decisions, and it's joint decision-making. So what about treating in utero with CFTR modulators? Now, this is an exciting and evolving area, I think. There are some case reports with regards to this. There's a case report of a baby born to a female with CF on modulators during pregnancy, and that female was born with a normal newborn screening, pancreatic sufficient, and normal sweat chloride. There's also been a male infant born with normal newborn screening, sweat chloride, and palpable vas deferens. So they thought that you could actually prevent that absence of the vas deferens if treated in utero. And then there's also a female infant of a female who did not have CF that showed meconium ileus on ultrasound at 23 weeks duration. And the mother was treated with modulators, and the meconium ileus resolved. So moving on to Australian Standards of Care 2024. So this is going to be published at CF Australia on their website. We've got about 8 standards with regards to what we should be doing to provide high quality, safe care. So standard 1 consists of focus on accurate information and counselling concerning fertility and pregnancy with all young people. Standard 2, as I discussed, we should have preconception counselling, and that should be offered to all people with cystic fibrosis. Should include genetic counselling and also focus on the health implications of pregnancy. Standard 3, assessment of fertility and referral to fertility treatment services if required. Standard 4, pre-pregnancy planning, so a detailed medical, nutritional, pharmacological and mental health evaluation, focus on diabetes, and access to psychosocial support should be provided as necessary. The obstetric care, so we do have links with our tertiary maternity providers, and there should be that combination and close communication with the CF team with regards to that. Patients that live rural and remote may very well need to deliver closer to home, but we still refer them to the tertiary services in case there's a need for that. Standard 6 looks at during pregnancy. People with CF should be reviewed frequently, which I've said previously, and that's to keep an eye on their physical and mental health. Standard 7, clinical care during labour and delivery should be led by the obstetric team, with the CF team providing support. And Standard 8, postpartum care should be jointly undertaken by maternity and CF services, with that emphasis on physiotherapy, nutritional and psychosocial support. And of note, given the case reports that I've discussed, the newborn screening status of the baby needs to be checked, especially if exposed to CFTR modulator treatment. And just to finish now my talk, I think it's important to discuss maintaining health post-delivery, both for males and females with cystic fibrosis. I think anybody that's had a child knows that the sleep deprivation that occurs with that, and that you maybe forget about your own health because you're focusing on this gorgeous new life, but there is that need to still focus on your health and have regular contact with the CF team. And also identify that support group that can help out if and when you get ill. So I'd like to thank the Adult Cystic Fibrosis team at Charles Gardner Hospital and all the patients and all of our support networks in Western Australia. Thank you. I think we're doing questions at the end. Yeah, okay.
Thanks very much, Siobhan. Appreciate that. I'd like to now welcome to the stage Jess Ragusa to talk to us about CF and fertility in a female perspective. Jess, a CF warrior, is a mum of 2 healthy CF-free boys and an ambassador for Cystic Fibrosis Australia, who knows the absolute importance of advocacy for our community, and I'm sure many of us are very familiar with Jess and all the work that she did in helping to bring Trikafta onto the PBS for those over 12, as after self-funding Trikafta for many, many months to actually just stay alive. So please welcome to the stage, Jess.
Hi. I did have my son here, as you would have seen, but he's currently yelling at everyone outside, so bear with him. I'm sure he will come and make an appearance. Yes, my name is Jess, and I am a mum of 2. Cooper is at home with Dad, and Cody is outside with Poppy, who is the most favourite person in our life, apparently, according to my boys. Cody's 9 weeks old. sleep deprivation, as you said, is at peak, so mind the bags under my eyes. For as long as I could remember, I wanted to be a mum. I wasn't overly career-driven. Sorry, guys, I'm going to get very sad. I never wanted to travel. I didn't want to go abroad. I wanted to be a mum. And I've been able to overcome that twice now. I met my husband James when we were 18. James had never heard of CF. He turned up to my appointments. He brought me chocolate milk and hot takeaway when I was in hospital. He proposed in 2018. And it was really exciting because we were planning our future. But for me, that was the hardest part because I wanted to have kids, but I didn't know what he was going to do, like what he would bring to the table. He obviously didn't have genetic testing because he never needed to. And I sat him down and I gave him an out. I said, if you were a CF carrier, I wasn't willing to take the risk of having a CF baby. I need you to get genetic testing. I needed you to get genetic testing, and I needed to know that my child was going to be a happy, healthy baby that wasn't going to be brought into the cruel world that CF is. The life sentence, the hospital admissions, the hospital appointments, having to isolate from my child when I was sick or when he was sick. It wasn't a choice. I need you to know that the possibility of us having kids naturally wasn't an option. Without hesitation, he booked the genetic testing. He said, let's just wait and see, but I'm not going anywhere. That blood test and the 16-week wait was the longest time in my life. We met with a geneticist who went through every single gene. Literally had no idea what he was talking about, not 1 ounce of it. We sat in a really small room. He was just throwing medical terms at us, literally nothing. Mum was there, James was there, I was there. We all just really looked at each other, very, very confused. So, what does that mean? We all just looked at us with really confused faces. No, he doesn't have CF. No genes that we've tested. Unless it's one of the weird ones that we don't know yet, you're most guaranteed to have a baby without CF. The boulder of the last 16 weeks that I've been waiting, paranoid that I was about to lose my fiancé and the possibility of having kids, gone. We were going to have a healthy baby. Little did I know how hard that was going to be for us. As we're in school, you learn when you have sex, you have a baby. You don't hear about the difficulties people have, or the fertility issues and the heartache that comes with it all. Growing up with CF, they never talk about infertility. If you ask, they bring it up, but it's never at the forefront of an appointment. And if they do, they go, you're a female, males have the problems, you'll be fine. That's not the case. CF takes a lot from you, and the possibility of having children is one of them. Similar to what Simone just said, it needs to be at the forefront of appointments, especially when you hit your teens, so you know what's about to happen. But for now, you get to hear my positive journey with fertility and pregnancy. So James and I got married in the 21st of March 2020, which was the Saturday before we went into lockdown due to COVID on the Monday. It wasn't long after that we started to try for a baby. Months and months passed, but there was no positive pregnancy test. My heart broke a little more. We had no idea why we were falling pregnant. So we were referred to more genetic counsellors, Mother Safe, and an IVF clinic. But because of COVID, a lot of our appointments were via telehealth. I don't even know who it was that we spoke to, but James and I were sitting outside having a telehealth. And they went through every bit of our history. Every result, there was nothing wrong. Just another thing that this awful disease takes from you. We were having a chat via telehealth, and the doctor said to James, "James, are you willing to raise a baby by yourself because Jess is going to die?" My heart actually shattered. I instantly sobbed. I'm talking snot dripping, hysterical, hyperventilating, crying. James was trying to contain himself because he was so taken back by that comment. But he somehow managed to respond. "Absolutely. It's half of me and it's half of Jess. So knowing I still have a Jess here is everything that I need and all the strength that I have." He knew my family would be there every step of the way. That's why they're here with me today. But they weren't expecting to make it to 30. So I was going to leave a baby less than 4 years old behind to be raised by my husband and my family. We managed to put the heartbreaking comment aside and continued trying for a baby naturally until our IVF appointment. Months later, we still weren't pregnant. My CF was getting worse. I had a constant chest infection and it rattled me. I was constantly coughing up blood and general house duties were becoming really hard. At this time, Trikafta wasn't available on the PBS, only to a select few people on compassionate leave access. My family had always considered self-funding it, but I never wanted to do that. I didn't want to have the financial and physical and emotional stress that $20,000 was going to cost. But it was after a scary hospital admission where I had pleurisy, Pseudomonas and Burkholderia cepacia that we finally took a leap. It was costing $21,000 a month, but that's another story. So in October of 21, we started Trikafta. At this stage, we still weren't pregnant. We tried hycoses, IUIs, ovulation tracking with bloods, with ultrasounds, nothing was working. By now, we were getting close to the top of the list, but it was December, so we closed for Christmas, we closed for New Year's, then my ovulation didn't work, it was just my luck. In February, the IVF collection was booked. We're waiting for my periods to start. But I noticed something different this cycle, something that I hadn't noticed before. And I said to James, "I think Trikafta is working. I think it's making my body do what it's supposed to do. The sticky egg white that people always talk about is happening to me." I actually think I said to James, "You need to pull your pants down now, get on the bed." It's time, I don't care what you're doing, this is what we're doing. 29 days kind of went and I hadn't got my period, but it was irregular, so no shock there. The nurses were calling going, "Has it happened?" "Oh no, not yet." "Okay, that's fine, just call us when it does." A few days passed, still nothing. So I decided to take a test. As many as I had done in the past. It's fine, if it's negative, you'll be okay. I said before that time stood still. Before I'd even finished my wee, those 2 lines popped up. I was speechless. How could it finally have happened? No IVF, just 3 little pills a day, and thanks to Trikafta, after 4 months on it, we'd fallen pregnant naturally. But now the fun and games of pregnancy got to begin. Being on Trikafta in the era, no one really knew what it meant for us, and all the unknowns, so I was having a high-risk pregnancy. I was referred to the maternal fetal medicine team at the Royal Hospital for Women in Randwick. From 12 weeks, I spoke to doctors and midwives every 4 weeks. I was referred to my local obstetric team at Gosford Hospital. So Gosford's 20 minutes from me, Randwick was 2 hours from me, so I needed to have a backup in case anything went wrong. So as you can imagine, there was a lot of appointments between monthly at Randwick and monthly at Gosford and every other test that you have being pregnant in between. They're expecting me to be sick, for my lung function to drop, to be put on oxygen for my 3rd trimester, and to be bedridden, because pregnancy was going to put a strain on my body. I don't want to complain about being pregnancy, because obviously I was so very grateful and it was incredibly exciting. And I knew the risks of having a pregnancy during CF, but it was very annoying. But for me, pregnancy was a breeze. The only complication I had was gestational diabetes. I didn't have morning sickness, I was never breathless, I wasn't anemic, I didn't have any of the complications that they say you would have when you had CF. Bub was growing nicely and I was well. At 37 and 4, my waters broke naturally, and the next morning I had my gorgeous little man, Cooper. He was a whopping 58 centimetres long and 3.74 kilos of absolute perfection. I had a normal vaginal birth with no complications. There was no need for Coopy to go to the NICU. Just to be cautious, for my CF, I had to stay for 3 nights, but I felt good. My lungs felt good. I was a mum. A year later, James and I fell pregnant again. Super exciting, but again came the high risk factor. And because I was running around after a toddler, they thought I was going to be sicker and tireder. It's not a word, more tired. So back to Red Week we went. Meeting with the team they'd put in place with Gosford again, and regular appointments were part of my monthly routine. But by about 16 weeks, I was fine. I had no other complications. I didn't have diabetes this time, but they were nervous that I'd go quicker and faster. They said, basically, we understand that you're high risk, but we have a higher chance of having more complications if you give birth on the side of the road than if you were to birth at a normal hospital, like as a normal patient at your local hospital. So birthing at Gosford was the plan. At 38 and 1, Mr. Cody arrived, a little shorter than Coop, but just as divine, by a normal vaginal delivery. Both boys had their heel prick test and both negative for CF. Obviously, they carry one of my genes, but that's a problem for them later down the track. I now have 2 healthy boys, and for myself, my lung function continues to sit in the 80s. Haven't had a hospital admission since starting Trikafta. Most of the midwives said I was actually healthier than a lot of their normal pregnant women. I'm currently breastfeeding Cody. Cooper self-weaned at 15 months. I took Trikafta through both pregnancies the entire way, and during breastfeeding. It was so new to market that they hadn't done a lot of research, and one of my biggest hesitations about starting Trikafta was the impact that it would have on them. But Mother Safe assured me that at the time, the research that was out was going to say that they were going to be okay. They both have 10 fingers and 10 toes. I had the option of coming off Trikafta, but at the end of the day, I needed to stay well. I needed to keep well so my pregnancies would be okay and for my boys to be well. So I did just that. So far, there's no evidence of Trikafta complicating anything. I see health nurses and GPs regularly, and for now, they're happy, healthy boys. I don't want to gloat, but I did pregnancy pretty well. No CF diagnosis was going to ruin this little girl's dream. I am a mum, and a boy mum of that. I look forward to the wild and dirt-filled adventurous future, from counting how many times they bump their head a day to getting a truck thrown at mine, to the fountain of pee streamlined on my face whilst changing nappies, or the wrestles and bruises to come. I wouldn't have it any other way. I am a mum.
Thanks, Jess. That was truly amazing. I take my hat off to you every step of the way. That's just gave me the chills. I welcome any questions. We've got about 5 minutes to ask a few questions. Does anyone have any they'd like to ask of either Siobhan or to Jess?
And who are well versed with the disease. Is there a network? I mean, Siobhan, for example, in Perth, is there parallels in other states? Are there networks of obstetricians that are connected with you that you refer people to, or is that the way it works?
Yes. So King Eddie's, we've got two specific consultants, and they're part of the Gold team, and they manage pregnant women with certain conditions, one of which is cystic fibrosis. So we've got an excellent relationship, and I think that really helps, that close communication. If something isn't quite right, we directly talk to them on the telephone. So I think probably every state's got their own setup like that, and the only time it would not be the case is if you're in rural and remote and the person would want to deliver close to home, but we still link them in with the tertiary hospital and those expertise with cystic fibrosis.
So the maternal fetal medicine team at Randwick were that people for me. They were the high-risk team that had the history of birthing mums with CF. So for my first son, for Cooper, it was you're birthing at Randwick because you're high risk. We need to know that you're okay. But with Cody, they allowed me to be at Gosford because I was well, but I constantly had Randwick in my back pocket at any time that I needed them, whether it was physicians or obstetricians, but they were who I was referred to. Before even my GP was like, that's well above me, you need to go back to your CF team, and they referred me to Randwick.
Hi, thanks so much for all of that. I've been teary through the whole thing, but thank you to all of you. For context, I'm a GP and I also have a daughter with CF. This is sort of a bit of a tricky one, maybe ethically, but right now, all Australians, so irrespective of whether they have CF or not, all Australian women can get genetic testing funded, so free genetic testing for cystic fibrosis and a couple of other things. So this is before they even decide to have a baby. Obviously, it's really tricky because if my husband and I had done that, then perhaps we wouldn't have had Ivy, because we may have then gone through the process of not having a baby with CF. Maybe if your parents had done that, you wouldn't be here. So that's obviously super complicated. But what do you think about that? Obviously, I haven't heard any talk about this at the conference at all, but obviously it's something as a GP that I want to offer to my patients, because we went through not knowing we were carriers, and then we have a child with CF who's very well, etc. But it maybe is tricky for you to answer, but what do you feel about that? Is that something you go, great, yes, I would really support everyone getting tested genetically to see whether they're carriers before they even get pregnant, or is that just too complicated?
So for me, that's only just recently become part of the bulk billing system. As a CF patient, James's genetic tests were bulk billed anyway, and I know that my brother also gets to jump on for that for me too. It's hard because I went through genetic testing before I'd even had kids. You thinking now that you don't have Ivy, I'd never had to think about because I didn't have my boys. But I would 100% recommend genetic testing, more because I am the patient. I know what it's like to be sick, and I know what it's like to have hospital appointments after hospital appointments. I wouldn't want to wish that on anyone. Nerve-wracking, and then I suppose it starts conversations about really important things down the track. But it's the same as the NIP tests. It's a conversation that you have to have whether you're going to continue your pregnancy if you're going to have a child with Down syndrome. I think it's just tough conversations, but I would recommend it. And I know, I will make my brother do it with his future wife or mother of his children. I just think that it's important to take the strain off the system, both as parents and then on the healthcare system as well.
I think it just highlights the importance of genetic counselling, particularly if there's a family history of CF, would be very important. And then above and beyond that, I think it's a very personal decision. You've highlighted it, but it is quite personal. Yeah.
I think I was in your situation, but I was never offered. I didn't know it was available. And so I think if I was at least given the choice, just to even know out of curiosity, and I had no family history of CF at all, and I think just knowing that it was available, I would have taken it. I'm quite inquisitive in that way, but I didn't know. So I think that it needs to be part of the conversation, I think, especially if you're of childbearing age.
We're 33-year parents of CF, and this just interests me. 30 years ago, at the CF conference in Brisbane, I think it's 30 years, a discussion evolved about prenatal testing, and things got pretty hot in the room because it's so incredibly personal. But our daughter, who's a doctor as well, she got married, and we supported her when she said, I won't test my partner until we're married. I thought that was pretty clever, a way to manage, because she didn't want to let cystic fibrosis rule her life. And I won't digress, but when we talk about mental health with siblings, I have a big opinion and a big coverage after 33 years of watching two siblings who are highly intelligent be affected by cystic fibrosis for their whole life with their sister, not their fault or hers. I just think somewhere there is an answer to people having to come to grips with CF in their family. We have zero history, both sides, long-standing families, known each other for 100 years, no history whatsoever. So that was the way our daughter handled it. She just left it out of her life until such time it was time. And she openly said to her mother, when they got the results back from her husband's test, that night it was on. And so I'm not being crude, just the reality that it is tough to deal with, because she has seen what her sister's been through, transplant, 160 weeks in hospital. It's a tough game.
I think for your daughter, she wanted to wait until she got married. I think, like looking back now, James was never going to leave, but I didn't want to have to be married and have that conversation of, well, I want a baby, well, I don't want a baby with CF. I never wanted that conversation, but I suppose it is very personal, as you said. Like, I'm 30 this year, so that conference is the same age that I am now. It's very, very personal, and I think you're never gonna know until you're in that situation anyway. But look, I hope that your daughter had a happy, healthy baby that isn't even a CF carrier.
She's only a carrier.
Yeah.
She's not like you. She's antenatal test. You can see we had one child at that conference. We subsequently had two more. You can see what decisions we made. That's fine. But it got so heated, the discussion. We realised, wow, we have to make this decision ourselves at home in private. And I just throw it up there for talk, because this is a lay program. I know that in the room there are a lot of parents and grandparents who have a lot of questions, and it's not easy. It's not easy.
No, and I agree. And, the person sitting next to you might think something completely different as well. And that's why you go home and you talk about it with your family. I don't think I never mentioned it to Mum that I wasn't going to have a baby if James was a carrier. I don't think that conversation come up until I'd even made him have the blood test. It was just a decision that I held on to, I suppose, because I knew how sick it was and I know how hard it is having CF. But thank you.
Thanks very much, everyone. I think we will wrap up this session. Thank you both, to Siobhan, to Mark, to Jess, for your time this afternoon and for presenting to us today. Bit of housekeeping. Afternoon tea will be served in the foyer area just outside, and our last plenary sessions will commence at 2:45 in this room. So please refer to the conference app for further details. So thank you very much, everyone.